it's an exciting time to be alive as a glaucoma surgeon.
Wouldn't be dead for quits.
No, no. And basically, one of the most exciting things is actually the future is already here. So, when I was going through my training, we were always talking about personalized medicine and precision medicine, which really means tailoring treatments and surveillance follow-ups to the individual patient. Because, we've got all this data about averages and average progression over time, but how does that help us figure out patient with a piddly glaucoma versus the one with a really aggressive type, right? We don't want to over surveil or over treat the one with the mild type, and we don't want to under treat or not review the one with the aggressive type enough. So the most exciting thing is genetic testing, which is developed in Australia. I alluded to it before, and it's available here in Australia. It's so simple, it's non-invasive, it's protected by the law, and it can really, really help the ophthalmologist guide treatment and guide the frequency of surveillance for that patient in front of them, not just based on averages. And I look after one patient who is a colleague of ours, actually, like in the eye health community and the medical community, and genetic testing has helped us make decisions, because it was sort of that time about, oh, should we do surgery? Should we not? Should we wait another 6 months and see what the visual field shows us? And that's how we used to treat people, in a very reactive way. That was probably fair enough, because the treatments that we had and the surgeries that we had and the techniques we were doing those surgeries were perhaps less finessed than they are now. And the risks, we've really managed to get those risks down quite a lot with improved techniques. And so now, using that genetic information, we can proactively treat people and say, look, your pressure is not optimal. We're having damage on the nerve and it's consistent over 2-3 visits. Why should we wait for the visual field to get worse? We can just take the next step, knowing that you're in the genetically higher risk category. And so this is how it helps us to give the patient information. And, as we all know, information is power to help make decisions. So that's the first exciting thing. Other exciting things, of course, are so looking into the future, the instruments that we have in terms of both the scans of the nerve and the visual field testing, I think we're going to basically have a better ability to extract much, much more data out of that and give us more precise data about what is progressing and what is not. And that's certainly in the open angle category. In the angle closure category, what's really exciting is so many people have narrow angles, like we discussed, the ones that look like this, but we don't know which ones are going to go into closure or develop pressure problems. And there are new studies looking into what we call anterior segment OCT, which is imaging, having really good cross-sectional pictures of the corner, 360 degrees of the eye, the size of the angle, the shape of it, 500 microns from the corner, how wide is it, etc. And those can all help us identify which patients are actually going to get the angle closure glaucoma or are actually at risk and need expedited treatment. And other things, of course, it's going to help us assess how good our surgeries are. So with advanced imaging and AI to look at those images and extract all this data from it, it's going to enable us to know a little bit more about the success of surgery and who's more suitable for which type of surgery.
So, of course, AI is revolutionizing so many things at the moment, but it sounds like it's also playing a big part in driving innovation in your world as well.
Absolutely. So it's going to be a good decision support tool. And I use that word carefully because AI can only identify links. It cannot identify causation. And some things that are linked may not necessarily be causal. So one may not lead to the other, but they just appear together more frequently for other reasons. And hence why you still need the human to do the higher processing of all that.
Right.
And you still need the human to talk to the patient and help them decide this sort of the science sort of things. But then there's the patient and their lifestyle and their responsibilities more often than not that drive the decision making. So even though the science can tell us A, B, C, and this is better, we speak to the patient about it, but actually the patient says, actually, I can't, comply with this post-operative regimen. So we need to do something else in the meantime that's perhaps less favorable scientifically, so not as the science doesn't show that it's as robust, but it's going to buy us a little bit of time until their situation improves and we can do something else.